Hi, my name is Hannah Norton and I'm a physical therapist and a fellow in training with Evidence in Motion's Manual Physical Therapy Fellowship Program. We're here to talk today about the diagnosis and management of rotator cuff pathology, physical therapy management of rotator cuff tendinopathy to rotator cuff tears. Rotator cuff tears are a common cause of shoulder pain and disability. Diagnosing and treating these conditions, however, can be difficult. The multifactorial etiology, the spectrum of clinical findings, and the wide range of pain complaints present in this population create a challenge for conservative management of patients with rotator cuff pathology. Clinical diagnosis for these conditions can be complicated. Special testing for shoulder disorders is often suspect for reliability and validity, resulting in the need to incorporate information from the history and demographic data and the combined strength of special testing into the assessment. However, management of these disorders from a conservative approach varies widely. Objectives today are to review common presentation for the spectrum of rotator cuff disorders, review current best evidence for diagnosis of rotator cuff disorders, and to review the best evidence for physical therapy management of rotator cuff disorders. So who gets rotator cuff problems? According to the New Zealand Shoulder Guidelines, complete tears are rare in those younger than 35 years old, and the majority occur in those between the ages of 70 and 80 years old. In that population, it is far more common to have no precipitating cause for the tear. Rather, they tend to occur over time. Interestingly, these tears are not often associated with functional deficits, regardless of the severity of the tear. Partial tears and rotator cuff overuse injuries can occur at any age, but are typically the result of a trauma or significant overuse. As we know, there are different degrees of injury associated with rotator cuff pathology, resulting in the spectrum of injury and management that we will discuss here. Tendinopathy, as opposed to tendinitis or tendinosis, is the best generic descriptive term for the clinical conditions in and around the tendons arising from overuse. Tendinopathy is a difficult problem, requiring lengthy management, and in the literature it seems that patients often respond poorly to treatment. A strain is defined as a mild injury to the muscle and is usually always present with impingement symptoms. A partial thickness tear is often quite painful, resulting in functional deficits due to pain inhibition and guarding. These tears often occur as a result of a specific injury or overuse in a short period of time. Full thickness and massive tears, as we discussed, often occur in the older population and can be pain-free, but may result in significant functional deficits if they occur suddenly as a result of a trauma. Tendinopathy is a gradual fraying of the rotator cuff over time, and the patient may develop compensatory patterns of movement if the problem does not result in acute tendon rupture. Pain may develop due to capsular restrictions, the impact of abnormal mechanics on osteoarthritis, overuse, and positional fault, among others. Patients' presentations usually vary, but generally they present with pain around the lateral shoulder, deltoid insertion, or even the elbow. Activities like overhead reaching repeatedly are common contributing factors for tendinosis. With a full tear, people often report that something serious has happened, or that they have torn something. As you can see from the picture in the middle, often different muscle injuries will refer to different parts of the arm, so it's important for us to remember this in our differential diagnosis for shoulder and arm pain. Shoulder injuries are common, but it can be difficult to identify those that require imaging to assess for surgical consideration. Now, X-ray is able to identify those who have chronic complete rotator cuff tears due to the upward glide of the humeral head, but MRI and ultrasound is required to assess for anything less. According to a review by Hegedus et al. In 2008, there is an 87% accuracy for ultrasound and MRI to identify partial and full thickness rotator cuff tears. Some other conditions that can result in similar pain patterns as rotator cuff pathology include the following: AC joint pathology, bicipital tendinosis, calcific tendinitis, frozen shoulder, and cervical referral or radiculopathy. It's important to keep these conditions in mind as we evaluate a patient with shoulder or arm pain, as the management for each of the conditions will differ greatly. For a complete tear, we have a few tests that demonstrate good utility for helping us rule in the condition. In other words, the sensitivity is fair, but they have really good specificity. These tests are the external rotation lag sign, which has a specificity in the load response of 28.0, and the internal rotation lag sign test, which has a positive load likelihood ratio of 16.0. The sensitivity is 0.31, specificity is 0.87 for the internal rotation lag sign test. It has been hypothesized that the degree of severity of rotator cuff disease impacts the diagnostic utility of special tests. Therefore, Park et al. In 2005 conducted a study to assess whether the combined accuracy of testing could be more successful. These tests were the infraspinatus muscle strength test, the painful arc test, the drop arm test, and the Hawkins-Kennedy. The combination of the Hawkins-Kennedy impingement sign, the painful arc sign, and the infraspinatus muscle test yielded the best post-test probability at 95% for any degree of impingement syndrome. The combination of the painful arc sign, the drop arm sign, and the infraspinatus muscle test produced the best post-test probability at 91% for a full thickness rotator cuff tear. If all three of these tests in the cluster are present and positive, then the result is extremely likely. So, though the objective findings may not actually matter as much when taken by themselves, we can still use them in combination to choose appropriate treatments for the patient presentation. Kokkonen et al. In 2014 performed a study assessing the treatments for non-traumatic rotator cuff tears. This was a randomized controlled trial comparing three groups: those that received physical therapy, those that received physical therapy plus acromioplasty, and then those that received physical therapy, acromioplasty, and a rotator cuff repair. The patients who were entered into this trial did have relatively chronic conditions of an atraumatic nature, and the patients were required to have at least a 75% supraspinatus tear documented on an MRI. Patients with osteoarthritis and tears involving two or more tendons were excluded from this trial. As you can see in this graph, there was no significant difference found in the outcomes among the patients treated for non-traumatic supraspinatus tears with three different interventions at a one-year follow-up. Contrary to the author's hypothesis, surgical repair of the supraspinatus tear does not improve the constant score when compared with acromioplasty only or physical therapy only. The same was true for the patient's subjective satisfaction. This Cochrane review by Green in 2003 looked at the efficacy of physical therapy interventions for treating shoulder pain. They did find that based on 4 trials of limited quality, corticosteroids were found to be superior to physiotherapy. They found that tendon rupture can be prevented by avoiding direct injection into the tendon. There is some evidence that supervised exercise is beneficial for pain and function, and good evidence that ultrasound is of no additional benefit over and above exercise alone. We still have a lot to learn about rotator cuff pathology and its treatment. Hay, in 2003, performed a high-quality pragmatic trial of physiotherapy where they compared subacromial injection of methylprednisone for people with new episodes of shoulder pain with physical therapy. Patients were treated for 6 weeks and they received up to 8 sessions of physical therapy. Now this was a pragmatic trial, so physical therapy interventions included a variety of treatments. All patients did receive advice and an at-home exercise program. 50% of patients received ultrasound at least one session, and 76 of 103 participants received mobilization to their shoulder at least once. There were no significant differences in outcomes found between the groups, though the physical therapy group did have some advantages over the injection group in that they were required fewer follow-ups with their general practitioner, fewer co-interventions after the initial 6-week trial, and they had the potential for improved self-management due to the advice and education by their physical therapist. This study by Bang and Dial in 2000 in JOSPT is a prospective randomized controlled trial with 52 participants. The participants were required to have subacromial impingement syndrome, meeting the criteria for pain and decreased strength. The two treatment groups were an exercise group, which received supervised flexibility and strengthening exercises, and then an exercise plus manual therapy group, which had the same exercise program as the exercise group, but with the addition of manual therapy. Each group received 6 treatments over a 3-week period. The outcomes were strength, pain, and function at baseline at the end of 6th visit and then 2 months after the initiation of treatment. The results showed significant improvements in both groups. However, the manual therapy plus exercise group demonstrated even more significant gains. In conclusion, the authors found that manual therapy plus exercise was better than exercise alone for increasing strength, decreasing pain, and improving function. In this case series by Tate in 2010, they included 10 patients. They described a standardized treatment program for subacromial impingement syndrome, including the time course and the outcomes over a 12-week period. The treatment was 10 visits over 6 to 8 weeks. They had a 3-phase progressive strengthening program. It included manual stretching, thrust and non-thrust manipulation to the shoulder and spine, patient education, activity modification, and a daily home exercise program. Success was defined as a 50% improvement on the dash and the grok, at least moderately better. At 6 weeks, 6 of the 10 participants were considered successful. At 12 weeks, 8 of the 10 participants had a successful outcome. They noted that the largest improvement was within the first 2 weeks of beginning treatment. So next, we'll discuss the management of full thickness and massive tears. As a quick note, it is recommended for partial tears and tendinosis that we refer to an orthopedic surgeon if the patient has failure to improve after 6 months or longer. For full thickness tears, rehab may be of limited benefit when the acute symptoms have settled. Early referral is indicated for patients who are physiologically young, but for older patients or those with chronic degenerative tears, they are not really ideal surgical candidates many times, so there is some evidence supporting physical therapy interventions to treat functional limitations and pain associated with their pathology. This small study by Ainsworth in 2006 demonstrates improvement in function for patients who are not surgical candidates, with a protocol focused on the interventions you see at the right. A description of the interventions used can be found by clicking the link at the bottom of this slide. In regard to strength training, we have several areas that we can discuss. One is the scapulothoracic musculature. Bang et al. In the 2000 article found that because the rotator cuff originates on the scapula, good strength and positioning of the scapula is an important aspect to rehab in rotator cuff pathology. Specifically to the rotator cuff musculature, Reinold et al. In 2004 did a study looking at EMG activation of rotator cuff musculature during various exercises. Data that was found in this study can be useful not only in exercise prescription, but also in identifying compensatory muscular substitution, as it tells us which exercises tend to recruit a specific muscle more than others. Baydar in 2009 did a study with 20 participants where they measured the change in isokinetic strength of the shoulder after a program of strengthening for patients with full thickness rotator cuff tears. They did note improvements in strength as well as perceived function, range of motion, and pain scores on the the ASES, constant score, SF36, and isokinetic testing. 55% of those patients reported that they were much better at 6 months, and 45% reported that they were better at 6 months. In looking at research about conservative treatments, often we find articles that utilized a multimodal pragmatic approach. These articles by Bang and Dial and by Tate are examples, which we can draw a plethora of information related to successful outcomes for patients with rotator cuff pathology. The manual therapy interventions here are varied, but the lists include a good regional interdependence approach for the entire shoulder, girdle, and cervicothoracic region that should be addressed for your patients with rotator cuff pathology. Activity modification is also a recommendation found throughout much of the literature in management of rotator cuff tears. Advice is to avoid activities that cause pain as much as possible, and ideas for compensatory movements are provided to assist the patient in appropriate performance of those activities. This study, Bader, analyzed the effectiveness of a conservative approach in 20 subjects with full-thickness rotator cuff tears. One of the aspects of treatment was activity modification. Another aspect of the treatment was strength training. However, when we look at patients who have more acute or massive injuries to the rotator cuff, we have to consider exercises that address range of motion. This article includes an exercise protocol to address these impairments and the exercise protocol is divided into 3 stages to ensure appropriate progression. Phase 1 of the exercise program includes Codman pendulum exercises, passive forward flexion, abduction, extension, external rotation, and internal rotation exercises with a stick, posterior capsule stretching, and then when full and painless range of motion was achieved, the patient was progressed to Phase 2. Phase 2 included strengthening of the rotator cuff, scapular stabilizers, and the deltoid. The use of TheraBand and free weights was allowed to provide resistance against internal and external rotation, abduction, extension, and forward flexion. The scapular stabilizers were strengthened by push-ups, shoulder shrugs, and shoulder press-ups. The last phase of the strengthening program involved reintegration of patients back into normal activities, including work, hobbies, and sports. Another aspect of this trial was that they utilized physical modalities. These have been moderately investigated in the literature for patients with shoulder pain, and in this trial, patients received therapeutic ultrasound, infrared radiation, and TENS. Research analyzing the use of these interventions independently has not shown strong effects, so use in moderation is encouraged. Another interesting aspect can be found by looking at this article by Braun et al. In 2011. They had 2 groups, one was a treatment and one was a control group that was simply waitlisted for 3 months. Patients in the treatment group attended sessions once weekly, where they received manual compression of trigger points of the shoulder girdle, as you see here. They also received manual stretching of the muscles and the application of cryotherapy with the stretching. Patients were instructed to perform muscle stretching and relaxation exercises at home, as well as receiving ergonomic training and cueing for postural correction. In general, outcomes were good. The primary outcome was the DASH, and as you can see here, patients in the treatment group fared better than those in the control group that received no treatment. Clinically relevant improvements were achieved in 55% of the patients with shoulder pain, and the number of muscles with active muscle trigger points was significantly decreased. Another method to address trigger points of the shoulder girdle is to apply dry needling. In a small case study by Cluley et al. In 2014, a patient with adhesive capsulitis was successfully treated using dry needling in a multimodal treatment approach. This infers that patients with myogenic dysfunction and pain can benefit from this treatment, and it might be beneficial for patients with pain resulting from other rotator cuff disorders. So, what do we expect to see in these patients with rotator cuff pathology after a bout of conservative care? This study by Tanaka in 2010 is a randomized controlled trial with 123 shoulders in 118 patients. The inclusion criteria were full thickness tears diagnosed by high resolution MRI. Each patient received conservative care for 3 months, and the following parameters were used to show significant differences: the integrity of the intramuscular tendon of the supraspinatus, the supraspinatus muscle atrophy, impingement sign, and the external rotation angle. The success rate of conservative treatment was 87% in the cases with at least 3 of these 4 factors. The criterion for failed conservative treatment was defined as a constant score of fair or poor, and those patients went on to have surgery. So in general, of the 123 shoulders, 65 were considered a success and 58 were considered a failure. In this study by Badar in 2009, they had 20 patients. The inclusion criteria was a full thickness rotator cuff tear. Outcomes were collected at baseline, 6 months, and with the addition of 1 year and 3-year ASES and patient response. It looked at range of motion, pain, ASES function, constant score, SF36, isokinetic shoulder strength, and the patient response. Treatments included activity modification, NSAIDs, physical modalities, and specific exercise program. There were statistically significant improvements in all areas, 55% reporting much better and 45% reporting better. In conclusion, we see that conservative treatment for patients with rotator cuff disorders can be very helpful. Treatment should be multimodal and address impairments and functional limitations. The use of exercise and manual therapy interventions is supported over the use of modalities. More research is required to identify patients at risk for failed conservative care.